It's now my pleasure to introduce Dr. Lorraine Lipscombe. Dr. Lipscombe is an endocrinologist and director of the Division of Endocrinology at Women's College Hospital in Toronto, as well as a scientist at the Women's College Research Institute, a senior adjunct scientist at the Institute for Clinical Evaluative Sciences, and an associate professor of medicine at the University of Toronto. She completed her MD at McGill University, followed by internal medicine and endocrinology training and a Master of Science in Clinical Epidemiology at the University of Toronto. Thank you, Dr. Lipscombe, for joining us today to chat with us about the Diabetes Canada Clinical Practice Guidelines.
Thank you very much for that introduction, and thank you for the opportunity to speak with you today. I'm just going to share my screen. Here we go. Share and to bring this up. Okay, great. I'm hoping everybody sees this and everybody can hear me. If not, send me a note, but let's begin. So it's my pleasure to talk to you today about the Diabetes Canada update, the 2020 update for the pharmacotherapy for type 2 diabetes clinical practice guidelines, and what is the evidence and what does it mean? I'm going to start with my disclosures. Mainly, I have funding from Diabetes Canada in the form of a Diabetes Investigator Salary Award, as well as from CIHR for a clinical trial. I also want to give a shout out to all of the people who have worked on the various iterations of the pharmacotherapy for type 2 diabetes clinical practice guidelines over the last 4 years. You can see the authors are all listed here with the latest group of authors who got together to review all of the evidence that had come out between 2018 and 2020 to be able to update our guidelines in October of 2020. You'll see their names here in the far most right column. Okay, so what are the learning objectives for today? So one is to describe the key findings of recent outcome trials demonstrating cardiorenal benefits of glucose-lowering therapies. 2 is to understand the rationale for the updated recommendations. And 3 is to be able to confidently use the updated flowchart and algorithms to select diabetes therapies based on patient characteristics. Now, I'm sure, as you can all appreciate, even though we did put out very comprehensive evidence-based guidelines for the pharmacotherapy of type 2 diabetes in 2018. By the time the chapter was published, those guidelines were already becoming out of date. There has been an onslaught of clinical trials that have tested diabetes medications, looking at their effects on cardiorenal outcomes in patients with type 2 diabetes. And because of that, we felt compelled to give an interim update on these guidelines rather than wait for the 4-year cycle that we usually do for our clinical practice guidelines. Many of those trials did result in substantive changes to the guidelines and are really have great implications on our clinical practice. And so I'm hoping that I can share with you the summary of those changes today. So this slide here tells you what the key changes have been for the clinical practice guidelines. And if you remember nothing else, this slide just basically summarizes what those key changes are. So number 1, we have created an updated algorithm on the management of type 2 diabetes. And number 2, and perhaps most importantly, we have new specific recommendations to select as priorities GLP-1 receptor agonists, or SGLT2 inhibitors, for cardiorenal protection in high-risk populations, notably, even if they don't require glucose lowering, even if the A1C is at target, we still recommend now that in certain populations, these medications should be prioritized. And those populations not only include people with atherosclerotic cardiovascular disease, like in the 2018 guidelines, but now also include people who have a history of low ejection fraction, congestive heart failure, or CHF, and chronic kidney disease, or CKD. In addition, another key change is that we're now recommending that one of these agents be prioritized in people who do not have any of those comorbidities, but are greater than the age of 60 and have multiple cardiovascular risk factors. Finally, we also recommend that these agents be considered as priority if avoidance of hypoglycemia and weight loss are priorities in your patients, even if they don't meet any of these other criteria. We've created updated tables of these major outcome trials to try and help you understand why we recommended these. We made these recommendations, and we've provided additional information promoting the safe use of anti-hyperglycemic agents, or AHAs. I'm going to briefly go over with you what has been unchanged from 2018. So one, as we've always recommended for your patients with type 2 diabetes, choose therapy after assessing glycemia, cardiovascular and renal status, diet, and weight change. Establish an individualized target for A1C. Reach that target as much as possible within a 3 to 6 month period. Individualize your therapy based on the characteristics and preference of the person with diabetes. And perhaps most importantly, and what's on a lot of people's mind, is we still recommend in your newly diagnosed patient with type 2 diabetes to start with metformin, plus or minus other concurrent agents. And I'll take a moment to explain to you why metformin remains first line for our patients with type 2 diabetes, despite all of the evidence that's come up regarding newer anti-hypoglycemic agents. And metformin remains first line for a few reasons. Number one, because we still only have evidence for metformin as a treatment for newly diagnosed patients with type 2 diabetes. So far, all of the other studies of newer agents for diabetes were conducted in patients who had established diabetes and were already on metformin. Therefore, we do not have evidence to guide new starts of other agents in newly diagnosed patients with diabetes who are not already treated with metformin. Secondly, there is evidence that metformin is safe. It is effective at reducing glycemia and has a long track record of tolerability, safety, and it is well accepted. And also, it is inexpensive and easy to take. Finally, we do have some evidence that it may be beneficial for cardiovascular risk reduction in patients with obesity. What else is unchanged? What else is unchanged is your initial choice of therapy is guided by your individualized target for A1C and how high above that target the current A1C is in your newly diagnosed patients. So I'm not going to talk too much about how to establish your A1C target for your patient. That is part of another chapter that hasn't changed since 2018. But in summary, in the vast majority of patients, the target A1C should be 7% or less, based on the UK-PDS trial, which showed benefit on microvascular outcomes when you target an A1C of 7% or less. Having said that, though, we know that for some patients, the risks of intensive glycemic control may outweigh the benefits of achieving a target of 7%, and therefore you may want to modify the targets, particularly in patients who are elderly, who are frail, who have limited life expectancy, and multiple comorbidities. And so there, the target can go up to 8.5% A1C. And so because of that, we do not give an A1C number at which we recommend starting medication. Instead, we ask you to establish your individualized target for your patient and then look at how far above that target is. So if it's less than 1.5% above target, so for a patient with a target of 7%, that would be less than 8.5%. You can start, just like always, with healthy behavior interventions and defer starting pharmacotherapy for 3 months if they're not at target, and metformin being the first line. However, if their A1C is greater than 1.5% above the target, we then recommend that pharmacotherapies be started immediately, namely with metformin in conjunction with healthy behavior interventions, and you may want to consider a second concurrent agent, particularly if the A1C is very high and it's unlikely that you're going to achieve your target within 3 months with just metformin and healthy behavior interventions. As always, if a patient has symptomatic hyperglycemia and or metabolic decompensation, or in your newly diagnosed patient, it's still not clear the type of diabetes, then you're going to want to start insulin right away, plus or minus metformin. And that can be temporary. Once the patient is stabilized, can be discontinued after. This is the updated algorithm. And just to point out, all of the information in the first part of this algorithm is unchanged since 2018 and just summarizes what we just talked about. So as always, at diagnosis of type 2 diabetes, you assess glycemic control, cardiovascular, renal status, dietary patterns, and weight change. You select your individualized A1C target. You provide and refer for diabetes education, and you start healthy behavior interventions. And there are chapters to guide these interventions. Your goal is to attain the A1C by 3 months, and you have 3 options. You can start with health, behavior, or lifestyle changes expected to reduce blood glucose levels without pharmacotherapy. You can start metformin plus a potential second concurrent agent. And if they have symptomatic hyperglycemia plus or minus metabolic decompensation, you will want to add insulin. If the A1C is not a target at 3 months, you either start metformin or you adjust or advanced therapy. And that is where we have changes, is for people already on metformin who either are not meeting their target A1C or have a clinical change in their clinical status, we suggest adjusting or advanced therapy. And that's what I'll talk about next. This is part 2 of the algorithm, reviewing, adjusting, or advancing therapy. And I have indicated in red where there are new recommendations. So number 1, in the 2018 guidelines, we recommended only adjusting or advancing therapy if the A1C was not at target on metformin. Now we've added a second decision node. So even if the A1C is at target, if there's a change in clinical status, you still will want to reconsider therapy. You will want to adjust or advance your therapy. And what are some of those changes that we ask you to consider? And that is over here. So as always, if they have atherosclerotic cardiovascular disease, you're going to want to adjust or advance their therapy. But now we also say you also want to adjust or advance their therapy if they have chronic kidney disease, heart failure, or they're over the age of 60 with 2 or more cardiovascular risk factors. And as a reminder, we've got it here in the small print, cardiovascular risk factors that have been included here are tobacco use, hyperlipidemia, and hypertension. Okay, so if your patient has any of these, meets any of these clinical criteria, you're going to want to add or substitute your anti-hyperglycemic agent with one that has demonstrated cardiorenal benefits. You want to add to metformin. And we'll talk about what those medications are and how you choose them. Okay, this is another table that we've created to help guide what to start in your patients who meet one of those clinical criterion. Here you want to add or substitute either a GLP-1 receptor agonist or an SGLT2 inhibitor, depending on 2 things. 1, your population characteristics, and 2, the outcome you're trying to prevent. Okay, and what we've done here is in green, we've put the highest level of evidence for each of the outcomes and populations, which is grade A in green. We've got grade B evidence, which is a lower level of evidence from the trials in pink. And then in blue, we've got the lowest level of evidence, grade C or D. Okay, so I'm just going to walk you through this to help you understand, and then we'll talk about the evidence behind these recommendations. So how do we decide, first of all, if your patient meets one of these criteria, atherosclerotic cardiovascular disease, chronic kidney disease, heart failure, or greater than 60 years old with 2 or more cardiovascular risk factors, you're going to want to start either a GLP-1 receptor agonist or an SGLT2 inhibitor or both. How do you decide which one? Okay, so first, if you have a patient with atherosclerotic cardiovascular disease, either agent has excellent evidence at reducing major adverse cardiovascular events, MACE. And major adverse cardiovascular events were the composite outcomes in the big trials that were looked at for these agents. And those include heart attack or MI, stroke, or cardiovascular deaths, okay? So both GLP-1 receptor agonists and SGLT2 inhibitors will reduce major adverse cardiovascular events in your patients with pre-existing atherosclerotic cardiovascular disease. But what about if your patient has atherosclerotic cardiovascular disease, but you also want to not only reduce adverse cardiovascular events, but you want to reduce hospitalization for heart failure, and you want to reduce progression of nephropathy? There's a greater balance of evidence that SGLT2 inhibitors not only reduce major cardiovascular events in this population, but also reduce these two outcomes with a lesser level of evidence. What if your patient doesn't have atherosclerotic cardiovascular disease but has chronic kidney disease? Here, again, we have the best evidence for SGLT2 inhibitors in that they reduce hospitalization for heart failure and progression of nephropathy in these populations. We have lesser level evidence for GLP-1 receptor agonists and even for SGLT2 inhibitors that they reduce major adverse cardiovascular events in patients with chronic kidney disease. As always, if they also have atherosclerotic cardiovascular disease, you can stay in this column. This is only for people who do not have cardiovascular disease but have chronic kidney disease. You may want to favor an SGLT2 inhibitor. And finally, if your patient doesn't have any of these two comorbidities but has a low ejection fraction heart failure, you're going to want to consider an SGLT2 inhibitor to reduce the risk of hospitalization for heart failure. Now, to make things more complicated, what if your patient doesn't have any of these comorbidities but is greater than 60 and has at least 2 or more cardiovascular risk factors? Well, the balance of evidence is actually greater for GLP-1 receptor agonists in reducing major adverse cardiovascular events. But you could also consider an SGLT2 inhibitor, but recognizing that in this population, we do not have evidence of benefit for major adverse cardiovascular events, but we do have some evidence of benefit on heart failure and progression of nephropathy in this in these patients who don't have pre-existing comorbidity. Now, the next slide will walk you through the rationale for where this evidence comes from. So this is a very busy slide that is part of our publication for the guidelines, and I'll try to walk you through it. So this table shows you a list of the relevant clinical trials in the first column for both the GLP-1 receptor agonists and the SGLT2 inhibitors. And you'll see among the subsequent columns the populations that were studied in these different clinical trials and the outcomes, the results of the outcomes that were looked at. Okay, so you can see, for example, here we've got a list of GLP-1 receptor agonists that have all been studied in various populations. We've got exenatide, liraglutide, semaglutide subcutaneous, semaglutide oral, dulaglutide, and albiglutide, which is now withdrawn from the market. For the SGLT2 inhibitors, we have empagliflozin, canagliflozin, dapagliflozin, and for canagliflozin and dapagliflozin, there were 2 major trials, one for cardiovascular patients with cardiovascular disease or risk factors, and then for canagliflozin for patients with chronic kidney disease, and for dapagliflozin patients with congestive heart failure. Okay, whereas you can see for the GLP-1 receptor agonists, all of the trials were done in patients who either had pre-existing cardiovascular disease or cardiovascular risk factors. So what about for your patients who have type 2 diabetes and atherosclerotic cardiovascular disease? As I mentioned before, both GLP-1 receptor agonists and SGLT2 inhibitors will reduce your major cardiovascular events. You can see All of these trials had either all or majority with cardiovascular disease, with the exception of Rewind for dulaglutide, which had only 31% cardiovascular disease. The remaining had cardiovascular risk factors. And in the vast majority of these cases, we saw a significant reduction in major adverse cardiovascular events, with the exception of oral semaglutide and exenatide, which did not show a significant effect. Just to point out, for oral semaglutide, the trial was actually very short and was not powered to look for benefit on major cardiovascular outcomes. It was powered for safety. And so had the trial gone longer, we may have actually seen a significant benefit. As you can see here, the point estimate is in the same direction as some of the other trials. And notably, if you look at the other outcomes of interest, cardiovascular mortality and all-cause mortality, oral semaglutide actually did show a significant benefit on these outcomes. So we really think that all GLP-1 receptor agonists likely have comparable effects on your adverse cardiovascular outcomes. Similarly, for SGLT2 inhibitors in your patients with pre-existing cardiovascular disease, canagliflozin and empagliflozin have both been shown to have significant reductions in major cardiovascular outcomes in pre-existing cardiovascular disease. And here you see here the actual absolute benefit in these populations is very similar for these two classes of agents. What about for your patients who don't have atherosclerotic heart disease but actually have chronic kidney disease? As I mentioned, in these patients, SGLT2 inhibitors reduce the risk of nephropathy progression. We saw that in C.E.T.S, which was a trial looking specifically at canagliflozin in patients with CKD, with a significant 30% reduction in progression of CKD. But you can also see that renal protection of SGLT2 inhibitors is seen in a broad range of people with type 2 diabetes. So patients with cardiovascular disease, or risk factors, you can see there was benefit on progression of kidney disease across the majority of those populations. Okay, next. And notably, when you're looking at your patients with chronic kidney disease, GLP-1 receptor agonists do not appear to have a significant benefit on progression of nephropathy, whereas SGLT2 inhibitors do. So you will want to focus, you will want to prioritize SGLT2 inhibitors in your patients with CKD if you want to reduce the risk of nephropathy. What about for people with reduced ejection fraction heart failure? You can see here that in the trial dapagliflozin was looked at in patients with reduced ejection fraction heart failure, and notably only 42% of that population actually had diabetes. And what we found is that there was a 30% reduction in hospitalization for heart failure with dapagliflozin, regardless of whether or not the patient had diabetes, but they all had heart failure. So definitely dapagliflozin can help reduce hospitalization for heart failure, but you can see that this effect was also seen in a broad range of patients with cardiovascular and chronic kidney disease. There was a reduction. So SGLT2 inhibitors seem to have a benefit across the board in reducing hospitalization for heart failure. And you can see once again here, just like for progression of nephropathy, the SGLT2 inhibitors have a greater benefit on heart failure events than the GLP-1 receptor agonists. Now, what about your patients who don't have pre-existing cardiovascular disease, but are over the age of 60 and have CV risk factors? So the evidence for benefit of these agents come from these two trials that I've highlighted here. One is the Rewind trial for dulaglutide, a GLP-1 receptor agonist, where only 31.5% of the patients actually had pre-existing cardiovascular disease, and the remaining were at high risk, greater than 60 with at least 2 risk factors. And what you can see here is that the dulaglutide reduced the risk of major cardiovascular events in that study. Similarly, in DECLARE-TIMI, interestingly, Dapagliflozin was tested in a minority, again, of patients who had cardiovascular disease. The remainder were 60 and above with risk factors. And what you can see here, there was no reduction in major adverse cardiovascular events in DECLARE TIMI with this SGLT2 inhibitor, but there was a reduction in hospitalization for heart failure and progression of kidney disease. So in your patients who have risk of cardiovascular disease but don't have pre-existing disease, if you want to reduce major cardiovascular events, you're going to focus on using a GLP-1 receptor agonist. If you want to reduce hospitalization for heart failure or progression of kidney disease, you're going to want to use an SGLT2 inhibitor. So either one would be indicated in this case, depending on where the priorities lie. And this is just to show you, for people with type 2 diabetes without atherosclerotic heart disease, that the GLP-1 receptor agonists have greater benefit on major cardiovascular outcomes than the SGLT2 inhibitors. And again, this is just to highlight for you, SGLT2 inhibitors do not reduce any of the major adverse cardiovascular outcomes in patients who only have risk factors for cardiovascular disease. So really, the SGLT2 inhibitors in patients without pre-existing disease, really their benefit is limited on heart failure outcomes and kidney outcomes. So that summarizes why we recommend using either an SGLT2 inhibitor or a GLP-1 receptor agonist in your patients who have one of these clinical indications. And I hope I've helped you try to decide which one to choose first in your patient, depending on which outcome you're trying to prevent and what comorbidity they have. Now, what if your patient has an A1C above target and glucose lowering is required, but they may or may not have one of those indications? In this situation, you're going to want to add or substitute an anti-hyperglycemic agent according to clinical priorities, just like we've always recommended. That this time you're now making a decision to add an anti-hyperglycemic agent to lower their glucose, not to lower their cardiorenal risk. And how do we decide that? So where additional glucose lowering is required, you're going to decide on what agent to choose based on the characteristics of the specific agent and your patient priorities and preferences. So we've separated agents into three categories. Agents that have proven cardiorenal benefit in high-risk populations, and those would be your GLP-1 receptor agonists and your SGLT2 inhibitors, which we've already talked about. Those that have cardiovascular safety but no proven cardiorenal benefit, and those that may have a higher risk of heart failure, and so that needs to be considered when you're choosing an agent. So when you're looking, so first of all, again, if a patient needs glucose lowering and they are from one of those high-risk populations that we already talked about, you're going to go along that same algorithm that we just talked about and choose a GLP-1 receptor agonist or an SGLT2 inhibitor. But if they don't require cardiorenal risk reduction, but you still want to have a drug that's safe, then you're going to look at what your patient priorities and preferences are. So if a patient wants to lose weight, you're still going to focus on the GLP-1 receptor agonists and the SGLT2 inhibitors. If weight loss is not as big a deal, but you want to make sure to reduce hypoglycemia, you can choose, still choose a GLP-1 receptor agonist SGLT2 inhibitor, but you could also consider a DPP-4 inhibitor such as sitagliptin or even acarbose, because they are safe and they don't cause hypoglycemia, but they don't have a big effect on weight. And finally, you want to make sure that you think about the risk of hypoglycemia if you need to start a sulfonylurea, meglitidine, or insulin. These increase the risk of hypoglycemia, and they also increase the risk of weight gain. So these should be reserved last, after you've looked at these agents. And then finally, we know that the thiazolidinediones, they may not cause hypoglycemia, but they actually are associated with weight gain, and they're associated with a higher risk of heart failure, as is saxagliptin, one of the DPP-4 inhibitors. So this one should be avoided, particularly in patients with higher risk of heart failure, as well as the thiazolidinediones. And this last slide now goes over the clinical factors to consider when selecting your anti-hyperglycemic agents. We talked about the big clinical factors in the previous slide, but these are obviously some other factors that you do not want to forget about. The individual's preferences and goals, costs and coverage. We know that some of the newer agents are quite expensive, and coverage really varies depending on insurance plans and provinces and age. A patient's goals of care and frailty, including life expectancy, and obviously their A1C target, side effect profile, medication intolerance, polypharmacy, right? You know, you don't want to be adding and adding and adding medications for no reason, and how high their glucose is. So if a person's glucose is very high, then we know that most of those agents have comparable effects on glucose lowering, but we know that insulin will have a more potent effect, so you may have to choose insulin in that case. And obviously, similarly, if they have symptoms of polyuria or polydipsia and weight loss that may indicate a need for insulin, then you may want to be thinking about insulin in these cases. You also want to be thinking about the renal function. We know that, I haven't mentioned this, but SGLT2 inhibitors are not recommended for EGFR less than 30. And we know that glycemic efficacy of SGLT2 inhibitors goes down as renal function declines. So they may not work as well for lowering glucose in your patients with renal impairment, even though they may reduce progression of nephropathy. Their eating patterns, need for blood glucose monitoring. Obviously, when there's hypoglycemia risk, then they're going to have to be monitoring their glucose. Dexterity for treatments taken by injection, such as the GLP-1 receptor injectable analogs, as well as insulin. Planning or potential for pregnancy. Many of these drugs have not been proven in pregnancy, and as many of you know, really the only drugs that we can use in pregnancy are insulin and metformin, possibly sulfonylureas, breastfeeding similarly, and of course, you want to be looking at your patients. Not everybody has the same kind of risk factors and diabetes profile. Some patients might have more of an insulin deficiency phenotype. Some might be more insulin resistant, and certain drugs work better than others depending on that. Finally, we also created an algorithm. We've updated the algorithm for starting and advancing insulin in your patients with type 2 diabetes. So once you've decided to initiate insulin in your patients, if their fasting glucose and or their A1C is not at target on anti-hyperglycemic agents, or their symptomatic hyperglycemia or metabolic decompensation, we recommend that insulin be started as a basal dose once a day, such as glargine U100 or U300, or degludec. NPH is falling out of favor because it is associated with higher risk of hypoglycemia compared to glargine or degludec. So you would start basal insulin once a day, usually at nighttime, and titrate to achieve fasting glucose targets. And you continue metformin unless it's contraindicated. And usually we recommend starting basal insulin, just to be simple, at 10 units, and you target a fasting glucose of 5.5, and you continue to titrate by 1 unit until you achieve your fasting glucose target. Now, if they're not meeting targets on basal insulin and they're not on one of these other agents, you could still add a GLP-1 receptor agonist, an SGLT2 inhibitor, and a DTPP4 inhibitor. Note that a GLP-1 receptor agonist and an SGLT2 inhibitor can be given in combination, as a DPP4 inhibitor and SGLT2 inhibitor can be. However, GLP-1 receptor agonists and DPP4 inhibitors are from the same family of incretin agents and therefore should not be treated together. Okay? And again, here we say for EGFR of 45 for glycemic control, 30 for cardiorenal protection. And then only after you've exhausted these other possibilities, and they're still not at target A1C, despite adequate titration of your basal insulin and supports for lifestyle and pharmacotherapy, you're going to want to think about Prandial or bolus insulin. And in this case, we also have a recommendation of how to start Prandial insulin or bolus insulin. And usually you will want to use one of the short-acting insulins, such as Aspart or Humalog, and you want to begin with one meal injection per day. And at this case, if they're on a sulfonylurea, you will want to consider stopping a sulfonylurea. You don't need to stop the sulfonylurea if you're just starting basal insulin, but certainly if you're starting bolus insulin, you're going to want to consider stopping it. And we say to start with one injection per day at the largest meal, because that has been associated with better quality of life, better adherence, and lower risk of hypoglycemia and equivalent glycemic control by 1 year than if you were to start all 3 injections at all 3 meals right off the top. So this may also give patients the time to get used to taking bolus insulin. And then you would advance to multiple injections at each meal if needed. Okay, so I'm going to summarize in the last 5 minutes. So I hope I've reminded you that the key messages. So one, we recommend regular review of clinical status and support of healthy behaviors as your patient is being followed for type 2 diabetes. Glycemic targets should be individualized. And in high-risk populations, those with comorbidity or risk factors, a GLP-1 receptor agonist or SGLT2 inhibitor is recommended for cardiorenal protection, even if the A1C is at target. And the conditions that you're going to want to look for are atherosclerotic cardiovascular disease, low ejection fraction CHF, or chronic kidney disease. And of course, in patients who are greater than the age of 60 with multiple cardiovascular risk factors. The choice of anti-hyperglycemic agents should be based on clinical status and patient preferences. Where weight loss is a priority, we recommend GLP-1 receptor agonists and SGLT2 inhibitors because they're both associated with significant weight loss. If reducing hypoglycemia is a priority, agents other than secretagogues and insulin are preferred. I will end there to give people time for questions.
Thank you very much, Dr. Lipscombe, for a great presentation. There are a couple of questions. I guess, in relation to pre-diabetes and the use of metformin. So one, I guess, could you comment on the use of metformin in pre-diabetes? And the second being, okay, so if it's okay to use metformin in pre-diabetes, why aren't we saying to start it with the diagnosis of type 2 diabetes?
Sorry. Oh, very good question. So metformin can be considered within prediabetes as well as at diagnosis for type 2 diabetes. The main thing that decides whether or not you should start metformin in either of those situations is whether there are substantial health behavior changes that the patient can make that will be expected to impact on their glycemic control. So if we see that there are significant diet changes to make, if they're very sedentary and they have the capacity to increase their physical activity, and if, of course, in the patients with type 2 diabetes, the glycemia is the A1C is not too high, then you may want to start with health behavior changes because we want to be able to give people an opportunity to do that. The other, and even with prediabetes, we know that lifestyle changes actually have a better benefit than metformin on preventing diabetes. And one other thing I want to mention is we also have good evidence now that weight loss, health behavior changes aimed at weight loss can induce diabetes remission in patients who are newly diagnosed with diabetes. So that is something that I didn't talk about today, but that is the other reason why we want to promote health behavior changes aimed at weight loss, because we know that there is an opportunity now. We have evidence that you can actually reverse diabetes and go into remission without starting medication.
Perfect, thanks for that. There's a comment here regarding the increasing complexity of pharmacological management of type 2 diabetes and its evolution. Wondering if you see the value of incorporating a clinical CD pharmacist into the structure of diabetes education centers. I know that's something that happens in some clinics here in New Brunswick. I'm not certain about other parts of the Maritimes, maybe what happens in Ontario currently.
So that's an excellent recommendation. And in fact, we do not have that routinely available either in Ontario. And it's a very important point. I think that given the fact that there's so much complexity and the fact that the recommendations are now, having to consider so many different factors, and also, the side effect profiles and the how to take these medications, has become more complex. I feel like, yes, I think that would be a wonderful initiative to have pharmacists as key parts of diabetes education teams. Currently, I rely on our community pharmacists when I start medication, particularly now that in the COVID pandemic where we're doing a lot of virtual care. I send prescriptions to the pharmacies and ask the pharmacist to then do the teaching and discussion about how to take the medications. So I think it would be a great addition.
Perfect. I see Tina has her hand raised. I'm just wondering, Tina, do you have a question or comment?
Proper treatment for a patient with type 2 diabetes with a pancreatitis.
Pancreatitis.
Yes.
So that's a really good point. I guess it would really depend. That's one that speaks to the point about insulin deficiency versus insulin resistance. So if a person has chronic pancreatitis and that's led to an insulin deficient state, then obviously you want to be prioritizing drugs that will increase insulin, like sulfonylureas and insulin, versus drugs that will work with a person's existing insulin production, like GLP-1 receptor agonists, etc. Or metformin. So yes, if a person has chronic pancreatitis and they have insulin deficiency, then the choices are more limited to insulin and insulin promoting agents. And particularly, even though we don't have firm evidence of this, there has been a longstanding concern that incretin agents may actually worsen pancreatitis, such as DPP-4 inhibitors and GLP-1 receptor agonists. It's currently not contraindicated in that situation, but it's something to consider in your patients with pancreatitis.
Perfect. There's another question there. Talking about, in obesity, they use a higher dose of semaglutide and some of the other GLP-1s. Wondering if there's any consideration to increasing the dose in folks with diabetes.
That's an excellent question. So if you increase the dose, it would be considered off-label. So you're using it for obesity treatment in your patients who have both type 2 diabetes and obesity, right? I mean, I do that often. I do increase the dose to the obesity indicated doses for patients with diabetes. And, that has two benefits. One, it will help with more weight loss benefit as well as potentially glycemic control.
Perfect. And the next question has to do with any role of SGLT2s in prediabetes at present.
So that's a really good question, and I know that some of my colleagues are looking at that in trials. And in fact, when we saw from the dapagliflozin DAPA-HF study, patients without diabetes benefited, dapagliflozin was safe and effective at reducing heart failure in people without diabetes. So I think we don't know yet, but potentially if you have a patient who has heart failure, there is evidence that even if they don't have diabetes, they may benefit from an SGLT2 inhibitor.
Perfect. The next question has to do with whether or not there's a diabetes prevention program available for people in New Brunswick. I can handle that one. Diabetes Canada has launched a formal diabetes prevention program. At present, there are no New Brunswick sites. I believe that there's a site in Halifax that has either just started or is getting underway. There has been some discussions about possibly having a New Brunswick site as part of that program. The program that has long existed in New Brunswick is the Live Well Bien Vive program, the health coaching program. So that is remains in place for anybody, any adult in New Brunswick that wants to work on any health goals. So yeah.
And I believe that the Canadian Diabetes Prevention Program is virtual. So I imagine you might want to see whether there is interprovincial opportunities for patients.
I think some of the issues came with like the drawing blood and all that kind of stuff for the research component, but hopefully it will be something that we're able to do in the future. We're almost out of time. We'll take maybe one more question with regard to off-label dose for accelerated weight loss. Wondering if there's any research into whether or not the patients are nutritionally compromised in the end.
I'm not sure I understand the question, just in terms of the medication causing nutritional compromise, or I don't understand.
Yeah, I guess what I take from it is maybe because the weight loss is so accelerated, does that lead to any nutritional compromise?
So I'm not aware of any concerns from that regard. I liken it to the effects of bariatric surgery. So obviously bariatric surgery is probably the best intervention we have for dramatic and rapid weight loss. And we do know that in those cases there is nutritional deficiencies, but that's largely related to malabsorption rather than the rapid weight loss. So I'm not aware of any concerns about nutritional deficiencies because it's not a malabsorption issue with the GLP-1 receptor agonist. It has more to do with appetite.
And that, yeah, that's exactly what she's actually getting at. So yeah, perfect. So thank you again, Dr. Lipscombe, for sharing with us about the guidelines. We really appreciate you being here. So thank you.
Thank you very much for the invitation, and I hope everybody has a good weekend. Bye-bye.
Bye-bye. So as we prepare for our next speaker, I will just let you know that we will be closing down entries for the scavenger hunt questionnaires really soon. So if you could get your entry in the next 1 to 2 minutes, it would be appreciated. And then we will make the draw for the scavenger hunt prizes following Dr. Holden's presentation. And I see Dr. Holden has joined us. So Dr. Robin Holden is a professor and chair of the Division of Endocrinology at Queen's University in Kingston, Ontario, and a consultant in adult endocrinology at the Kingston Health Science Centre. She served as a diabetes advisor with C.E.T.S and has been a long-time contributor to the Diabetes Canada Clinical Practice Guidelines, serving as chair of the 2018 version. Welcome, Dr. Holden, and thank you for agreeing to speak with us about perioperative and peri-procedure glycemic management, which is, something that we talk about frequently in diabetes. So we're always glad to hear more.
Oh, thanks very much. And it's actually my favorite topic. So I was actually thrilled to get asked to speak on this, because usually I get lots of guideline talks. So I'm really thrilled that you've asked for this one. So these are my disclosures. And a lot of the material is based on guidelines from the UK National Health Services. They were one of the first groups to come out with some very nice guidelines, and I've got the link to it online, and then also based a little bit on Diabetes Canada clinical practice guidelines. And then we actually have a paper group of us that have prepared that we're hoping will come out in the Canadian Journal of Diabetes sometime this year that has a lot of the protocols and material that I'm going to be showing you. Okay, so what are we going to try and accomplish? You're going to understand the benefits of perioperative glycemic control. I'm not sure I have to persuade you about that. And then we're going to look at some, people said make it practical. We're going to look at some management protocols that we use here in Kingston, and happy to share it with you then. Okay, so how big a problem is this? This is a big problem. Just the prevalence of diabetes is increasing in the general population, so it is not uncommon to meet it in hospitalized patients, patients undergoing surgery. And it's very common in certain populations, particularly in patients undergoing cardiovascular procedures and patients undergoing bariatric surgeries. And I've just written here that sometimes it's been diagnosed and sometimes around the surgery it's picked up for the first time. So this is a large study on over 7,000 people who are undergoing CABH, and 30% had diabetes, and they found when they screened for it, 5.2% had unrecognized diabetes. And that's really true for my center too. It's about 30% of the cardiac surgery patients that have diabetes. We did our own audit a while back. And even if people don't have diabetes, it's very common to get post-operative hyperglycemia. And I've got some references there, 24 to 40% of general surgery population and up to 80% of the cardiac surgery population getting perioperative hyperglycemia, even if they don't have a diagnosis of diabetes. So when people undergo surgery, it's a metabolic stress that will often drive blood glucose levels up. There's periods of starvation, and when you're starving, you release catabolic hormones which drive up blood glucoses, and you inhibit your release of anabolic hormones like insulin. And in addition, for people that are already on insulin, insulin requirements can go up from the stress, from underlying infections, from the use of steroids. So lots of stress during surgery, release of stress hormones, sometimes use of steroids, sometimes use of parenteral feeds. People aren't exercising as much, leads to hyperglycemia. But we know from lots of studies that if you have hyperglycemia, you get decreased immune function, you get decreased wound healing, you get endothelial dysfunction, release of inflammatory factors, fluid shifts. So what we're always trying to do is break that cycle. So if you have blood glucoses around the time of surgery, with or without a history of diabetes, it will predict your risk of having a post-op infection, and your risk of thrombotic embolic events, cardiovascular complications, renal insufficiency, and longer length of hospital stays. So there's good evidence that this is an important topic. So we look at cardiac surgery patients. Their pre-op A1C will predict their risk for mortality, MI, deep sternal wound infection. So from one study, if the level was over 8.6%, four-fold increase in those complications. And I have put a picture there of sternal wound infection. They're terrible looking things if you've been involved in any patients with those. For non-cardiac patients, your pre-op A1C just over 8%, associated with longer length of hospital stay. And if you had a value less than 7%, less risk of surgical infections. If you look at the bariatric patients, pre-op A1C, increased risk of wound infection, acute renal failure. And if you look at, even in the orthopedic literature, if you look at patients undergoing joint replacement surgery, your higher your A1C, the more greater risk of having a joint infection following the procedure. Now, what's really frustrating, you know, I'm a guideline person, and I love evidence, and I love reviewing evidence. So there's all these studies that show if your pre-op A1C is high, you're going to get more complications, but nobody has ever done a study to show that if you lower the blood glucose and improve the A1C preoperatively, you get better outcomes. And I guess it'd just be a lot of work to sort of, and hard to randomize patients to improving A1C, not improving A1C, and then looking at outcomes. But it's kind of a little frustrating because the evidence is lacking, and evidence is lacking for what the A1C should be precisely. So it's hard, and when you're writing up guidelines, to come up with very dogmatic, evidence-based statements. Okay, the other aspect of it all is patients with diabetes often have comorbidities. So they're much more likely to have cardiovascular disease, and that cardiac surgery, I should say any surgery could precipitate a cardiac event in them. And they're also more likely to have microvascular disease. They could have a deterioration in their renal function, or you can get into things like risk of heel ulceration. So that's another important consideration to it all as well. Now, my nurse practitioner came up with this image, and she was just showing all the surgical pathways. She said that patients can be admitted for surgery from the emergency room. They can come from the wards. They can come from outpatient clinics. She said that they typically will see the surgeon, that often there's a preoperative assessment, then they go to the operating room, but sometimes they come in not from the wards, they come from a same-day admission unit, then they'll go to the recovery room, sometimes they'll go back to the ward, sometimes they'll be discharged. But the whole key to the picture is that you want to have advanced planning, and that you want to have your patients involved throughout the whole process. So even though I have spent hours in my own healthcare institution trying to improve things, just this week, I got called from the preoperative assessment unit, and they had brought in a patient with type 1 diabetes. There had been no advanced planning, no A1C measurement, and the person's surgery was in 2 hours, and they said, fix everything up. And I said, this would have made a great consult 2 weeks ago. It's hard for me to do this now, but of course you have to go down and do it. Okay, but I hear these stories all the time. You hear them from patients. So here's one patient writing, I was booked for surgery. I was worried about how they were going to manage my diabetes. I was told I was going to be first on the list. I was told not to eat after midnight. I was told not to take my insulin that morning. And then I showed up, and the surgeon said, your last case of the day. And I said, I have type 1 diabetes, and they looked shocked. So it's just like that patient this week. Okay, and then here's another patient writing, I was put on a sliding scale after my surgery. I said, I'd like to go back on my usual, probably intensive insulin therapy program. They said, no, we use sliding scales here. They said, we have somebody come by next week. It's a holiday weekend, and this person got frustrated, went home and managed their diabetes better than what was happening in the hospital. And then here's another patient talking about how they're on the wards and that the timing of their insulin didn't match the timing of their meals. And they said that it was very frustrating. They were getting hypo and hypoglycemic episodes that they didn't feel that they needed. So I'm sure you could write up your own stories from stories you've heard from patients, coming back to you later to your diabetes education programs and telling you these horror stories. So if you want to make things better in your institution, you gotta form a team. You have to have somebody sort of spearheading it, and the higher up you can get support, the more likely you're to have success. So you want higher administration in a hospital to be supporting all your efforts as well. So finding your champions is really, really important. And then you want to form your multidisciplinary team. You can have an endo. If you don't have an endo, it might be an internist, an intensivist, a hospitalist, nurse practitioner, nurse specialists, pharmacists, dietitians, surgeons, anesthetists, all tackling this problem and coming up with common strategies together. And there is some evidence that this is cost effective. If you're trying to persuade your institution to help you fund maybe this type of a team, you could bring up this paper from Garg from 2018, and they formed one of these teams. What he picked was, he said, if your pre-op A1C is less than 8%, we want to see you. And we want to have our team come up with a management plan. That's fantastic. And he was able to show that they came in, they had better sugar controls, that they were more likely to be consulted in hospital to follow these patients. They had lower sugars on the day of their surgeries and throughout their hospital stay, and no increase in hypoglycemia despite that reduction in blood glucose. So form your teams. Now, in my institution, one of the biggest things that ever happened to me was I was able to get some nurse practitioners. And we have an inpatient diabetes consult service. It's staffed by 2 nurse practitioners now that are CDEs, and we have 1 diabetes nurse educator. And they are just run off their feet. They're running around the hospital all day long, managing diabetes everywhere. So they do patient education. So for someone that's never been diagnosed before, they might be doing education. If someone's had diabetes, they might be reinforcing education they've been receiving before. They're also giving advice to the medical and nursing staff. So it really varies from unit to unit. If it's an internal medicine service, often they're just asking help with really complex case scenarios, patients on parenteral nutrition. On a surgical floor, they might do total management, diabetes management for the surgeon. They might just say, we want you to order all the insulin and adjust the insulin doses for us. The team's also going around doing constant education to medical and nursing staff. They're championing our order sets and teaching everybody on how to use them. They're talking to all the specialist team, and they're really intimately involved in the discharge planning process. It's just become invaluable. And if you've had trouble trying to get funding for this, maybe we could chat at the end of the presentation about some of the strategies I use. Once you create the service and everybody sees how valuable it is, it has its own life. And I think we could stand even more people on our team now. We're just so busy. We'd like to have someone supporting the cancer clinics better, the renal clinics better. The other big thing that really helps you is to have order sets. And there's evidence for this as well. If you have standardized diabetes guidelines or order sets, typically you'll have better glycemic control in hospital. Okay, so what's associated with bad outcomes? If you haven't identified people ahead of time, done planning, you don't have order sets, your nursing and medical staff don't have good knowledge. So all the things that my diabetes inpatient team's constantly doing. If you don't allow patients to participate in the management decisions, people that are well educated, and those were some of those comments we were hearing about for people that were frustrated and trained on intensive diabetes management. They wanted to be more involved in their own management decisions in hospital. And then you're thinking about medications and sometimes reassessing medications in hospital after procedures and adjusting medications based on change in renal status. And then insulin, I've written here, it's life-saving and life-threatening. I think there are one of those top high alert medications for medication errors. But one of the big things you do in your institution is you start to train everybody that insulin should never be stopped in someone with type 1 diabetes. And that actually is what prompted that consult for me this week. The anesthetist called me up. It turned out the patient hadn't taken any insulin since the day before. They were now MPO. Their surgery wasn't going to be till the afternoon. And the anesthetist said, I know that you never stop insulin in someone with type 1 diabetes, so I need you to come and help me. And I was really happy that I had brainwashed the people in my institution enough that they realized that this was a big no-no. When you're doing your pre-op assessment, you want to look at your A1C. It's really important to do that for people without diabetes. But if you're seeing somebody and they've got lots of risk factors for diabetes, this is your opportunity to screen for diabetes and identify people with pre-existing diabetes that haven't been diagnosed yet. And then I've even put there that knowing those high rates of diabetes and postoperative hyperglycemia and the adverse outcomes, there might be a role for just routinely doing A1Cs in people undergoing cardiac surgery, without diabetes that is, vascular surgeries, bariatric surgeries, and even patients undergoing joint arthroplasties because of that high prevalence of undiagnosed diabetes. You want to refer people that you found have diabetes that didn't know about it before for education and management. Now, in our center, we have kind of this 8.5% rule. And if the A1C is above 8.5%, we really want them to refer to an endocrinologist internist to try and optimize, if possible, preoperatively. Now, as I was telling you earlier, why 8.5? There really isn't strong literature to tell you it should be 8, it should be 9, it should be 8.5. But 8.5 works pretty well. And I think most kind of expert groups, opinion-based groups, say 8.5 is a good zone to refer these patients. And so it's just nice to pick a number for your institution. and then start educating everybody that you've got services available to help that population. Think about the cardiac, renal status, the at-risk foot. You want to make sure that high-risk patients that are going to need critical care post-operatively are identified. So in my institution, we can't run IV insulin on the wards. And if we have a patient who needs IV insulin, then they've got to go to a critical care bed, a step-down bed post-operatively, and it's really important that that's been identified ahead of time. And that we have our order sets filled out ahead of time. I'm going to show them to you, and that they're shared with everybody on the team, and that we give written advice for patients about that period of NPO, so what they should do for that. And I'm just showing you part of that, but if patients, a lot of our procedures now are done as patients coming on the day of their procedure. And if they've been fasting, it's really important that they be prepared to treat any hypoglycemia, so that they have dextrose tablets or clear juice or regular soft drink with them to treat the low, and that they're going to tell when they arrive at the hospital that they have to treat hypoglycemia, and whether the procedure might have to be delayed by a couple of hours or not will be up to the anesthetist to decide. Okay, so this table, no evidence, okay? So it doesn't matter whether there's evidence or not, though. It just matters that your institution has taken the time to come up with guidelines that everybody can agree on, and that you're going to live with them, okay? So these are recommendations that we use in my institution. And we just say, for example, with metformin, they take it right up to the day of the surgery. And as I say, where's the evidence? You should stop the day before, the day of. It doesn't exist. But the key is that you take the time to come up with this, and that everybody lives with it in your institution. Okay? Same thing with the DPP-4 inhibitors, up to the morning of surgery. And if you look at the sulfonylureas, we say hold the day of surgery. SGLT2 inhibitors, we stop them 3 days pre-op. So it's kind of that sick day management rule. Okay? So you hold them around periods of dehydration. We're being cautious. We don't want to worry about euglycemic DKA. We stop 3 days before. Where's the evidence for that? Doesn't exist. Just come up with a recommendation. Make sure that everybody lives with it. And the GLP-1s, we say don't take them the day before your procedure, just in case you get nausea the day after your injection. So as I say, this is just all kind of consensus, expert opinion type of recommendation. These are the order sets that we use at our hospital. So when we identify patients preoperatively, if we can, we fill these out ahead of time. If not, we're filling them out when they're admitted. And as you can see, we say consult endocrinology, consult diabetes consult. Diabetes consult, the endocrinologists cover it on the weekends, but during the week, we're both around, we both support each other. And then we've got some recommendations for monitoring, and we just say pre-op every hour and intraoperatively every 30 minutes. And then the PACU, we're saying every 30 minutes for 2 hours, and then every hour. And there again, just spelling it out ahead of time, having a recommendation everybody will live with and will agree with. And then we've got a recommendation to start a dextrose-containing fluid if the blood glucose is less than 5. Otherwise, we use non-dextrose-containing solutions. And then on the next page, you have to pick a profile. And we created 3 patient profiles, as you're going to see. Profile 1 is a patient on insulin, and their procedure is going to be less than 4 hours, and it's expected they're going to eat afterwards. And in that case, we tell them to take 75% of their usual dose of insulin the night before, and if they do take a long-acting insulin on the morning, to take 75% on the morning of the procedure. Where does that 75% come from? Not great evidence, but I've given you that one reference. There's only one paper by Dema from 2017. They dose reduced everybody by 25%, found out it worked out most of the time. Now you might individualize it. Someone in really tight control, someone with terrible control, you know, you might up it and down it, but generally 75% will work well for you. And then we have a correction scale that we order. Our order sets are all electronic, so that there's a pull-down menu. We have most of the insulins on formulary. And then our correction scale is based on your usual total daily dose of insulin. So many different ways of doing this, but as you can see, we use insulin sensitive. If you use less than 40 units a day, We use insulin usual 40 to 80, and then insulin resistant, we have another scale if you're using more than 80 units a day. But this is the correction scale. And then we say you use it preoperatively if the sugars are high, use it in the PACU, but you can't give this insulin more often than every 4 hours. Then we have another profile. This one's different. This is a patient who's on insulin, but it's going to be a big procedure, more than 4 hours, and we don't expect they'll be able to eat afterwards. Okay? And in that case, we run IV insulin. So we dose reduce the night before, 75%. And then when they arrive to the same day admission unit, we start IV insulin. Okay? So our IV insulin order set is really fancy. And it was really hard to bring it into my institution. And it took a lot of training, but I finally got it in. I really envy hospitals that can have an IV insulin order set, and it's computerized. You just enter the current blood glucose, the lost blood glucose. It does calculations, and it throws up on the screen how to adjust IV insulin. But those programs typically are very expensive to purchase and use. So ours is still electronic entry order set. Okay. So we have it when they come in that you start the insulin based on the blood glucose. Why do we do that? Because we found that nobody was able to calculate total daily dose. That's a much better way. If they would calculate the total daily dose, you could start it based on the total daily dose. But the surgeons and anesthetists were not going to calculate total daily dose. So we said, okay, just start based on what the blood sugar is. Not a perfect method. But as you can see, our system gets into action really fast, and we'll start to bring the sugar down really fast. So this person comes in with a blood glucose of 12, okay? So we picked 2 units per hour. Then we said, oh my God, it's really common for the cardiac surgeon patients to get, without diabetes, to get post-operative hyperglycemia. And we said there are other patients that maybe will get post-operative hyperglycemia. So we said for stress-induced hyperglycemia, those cardiac surgery patients, even without diabetes, we want you to start the monitoring, and we want you to start IV insulin if the blood sugar goes over 10. So that's how we handle those patients, just knowing that those cardiac surgery patients with that post-operative hypoglycemia, the high risk for those complications, external wound infections, others, that we were going to start the monitoring, and if they went over 10, that's stress hyperglycemia, we were going to start some insulin. Okay, and then this one is just that we're going to start a dextrose-containing fluid in this scenario. And then here, one's really complicated. This is our monitoring. And then you'll have the slide. This gets published eventually. But basically, it says that the sugar's low, do tons of monitoring. It says when you first start it, check it every 30 minutes for an hour. So this is how our drip gets into action really fast, irrespective of what the starting rate was. If it says if they're in the goal zone of 5.1 to 10, you can go to every hour. But if you make a change, you've got to go back to always got to stay at every 60 minutes. If you make a change, it says if things are really stable, you go out to 2 hours, you can go out to every 4 hours. Never happens. Okay, most patients, if they're lucky, if they're really stable, get out to every 2 hours, but rare to get out to every 4 hours. Okay. And then we have this rate of change calculation. Now, this one is really fancy, okay? And your institution may not be ready for this, but what we do is we say you look at the change in the blood sugar, and you look at what the sugar is now. So this person's blood sugar is 12, and so it's over 12, and it's risen by over 1.5. It went from 12 to 14. So we say the sugar went up more than 1.5. It's at 14 right now. We put the two together, and we see we have to double the drip. Okay? Now, the worry with this is you got to do tons of staff education. You got to educate people how to do math. But what they do is they say the drip's running at 2 units per hour. I got to double it. It goes up to 4. Okay? So then let's see what happens next. Next one is that now the sugar has dropped from 14 to 6. That's a big drop. Now, some drips would say, hey, this is great. The sugar's 6. It's in the zone. But a smart drip says, hey, that was too big a drop. I need to start slowing myself down. So this time around, the drop's been greater than 1.5. And the sugar right now is 6. So you have to multiply the current drip by 0.25. So the drip goes from 4 to 1. Okay, so this is what we do in our institution. Took a long time to bring in, but it works out really well. And that's the IV insulin for people undergoing big procedures, going to be NPO for periods of time. When you go to transition people from IV insulin back to sub-Q insulin, you want to do an overlap, and you want to try and overlap for 2 hours. So you give the first injection, and then you will stop your IV insulin 2 hours later. And this is just the formula for doing that. Okay, so basically you look at what they were taking over the last few hours. If they were eating on it, you would think, hey, I would just take that usual rate over the last few hours, multiply it by 24. But just to be safe, we dose reduce by, we just give 80% of it. So you multiply by 20. Instead of 24, 80% of 24 is 20. And if they weren't eating on the drip, you multiply by 40. So you make up the missing bolus. You should be double what you were getting if you weren't eating on the drip. Okay, so this is a little complicated one to explain to house staff, but you can do it. So here's my person. They're on 1 unit per hour for the past few hours, but they weren't eating. So if they were eating, I'd multiply by 20. If they aren't eating, I'm going to multiply by 40. So give them double what they should be getting, and then give half as basal, half as bolus. Okay, what about pumps? We have all sorts of rules for pumps. So it's our last profile. We have tons of pump users in our center. So we say if you're on a pump, it's a short procedure. There's not going to be any electromagnetic exposure. We let them use their pumps. We run at 80%. We say if there's going to be electromagnetic exposure and the surgery is less than an hour, they just disconnect from the pump. If the surgery is going to be 1 to 3 hours, there's going to be electromagnetic exposure, then they're going to give themselves a little injection of bolus insulin just to make up for the missing time they're not going to be on the pump. And then if the surgery is over 3 hours, then we switch them to IV insulin. So it's, as I say, it's just coming up with the protocols ahead of time, identifying these patients ahead of time, having the sheet filled out ahead of time. Everything works out really well in our institution most of the time. Okay, interoperatively, Diabetes Canada guidelines tell you what the goal targets are. I don't know. I'm happy 5.1 to 10. That's kind of what I'm aiming for most of my patients. And then there were recommendations about the frequency of monitoring as well. I think in the guidelines we missed things about what happens in the operating room, what happens during a C-section, but we have these on our order sets, how frequently we want people to monitor. And in the post-operative period, where's the evidence? There isn't. Just your group needs to get together and decide how you want to handle things. Basically with metformin, you want to just confirm that the renal function's fine. The DPP-4 inhibitors, there again, if there's been a change in renal function, you might need to dose change some of them. The sulfonylureas, you can restart once they're eating. The SGLT2 inhibitors, we tend to hold those throughout the whole hospitalization. So until they're discharged, then we tell them to go back on. And the same thing with the GLP-1 receptor agonists. Sometimes people don't have perfect sugar control. We never let people keep people in hospital for this. We just make sure that they're talking with our diabetes consult service, their endocrinologist, whoever else is willing to take responsibility for the diabetes to keep adjusting. Post-discharge, sometimes insulin requirements go down as they get better. So you don't delay discharge, but you always make sure that people have numbers they can contact to get hold of people for help. And make sure that if you've changed anything in hospital, you explain those changes. You've given them the appropriate prescriptions that you've talked about, hypoglycemia management, sick day management. Okay, and now with time, I'm not sure I'm going to have a ton of time here to go through how we manage colonoscopy, but we have a sheet that we've prepared. And we share this with the gastroenterologists and with patients so that, once again, everybody's agreed on a standard approach. And basically, it talks to them about the diet for people with diabetes when they're undergoing colonoscopy, and it gives them the choices they could do and how many grams of carb these choices have. We've got a sample menu that we show them. We tell them about how to manage their anti-hyperglycemic agents. And here again, we're telling them, stop those SGLT2 inhibitors 2 days before the procedures. With these other ones, take as long as you're eating solid food. Don't take yourself on ureas. And then we have suggestions for managing insulin. But basically, we're dose reducing as well, just like we would with surgery, typically by, 15 to 20%. And then for the pumps, that they're going to run a reduced basal rate during the procedure, and 80%. I've got 50 to 80%. Okay, so just so we have time for questions. Perioperative hyperglycemia is common. We know that it predicts risk for post-op infections, thrombotic events, cardiovascular complications, renal insufficiency, increased length of hospital stay. I'm thrilled that you're interested in this topic. That it needs to be a seamless process, advanced planning involving the patients, coming up with order sets in your institution, coming up with your team, coming up with your clinical leads. And I've shared with you some of my order sets. You've got the slides. I'm happy to share them by email as well. We do hopefully have a publication coming out on this topic this year in the Canadian Journal of Diabetes, which is going to have a lot of these protocols embedded in it. Okay, so I think I'm ready for the questions now. Okay.
I had started to look at some of this stuff in, pre-colonoscopy and all that kind of stuff a little while ago, because it seems there's always that end of the afternoon phone call the day before the procedure saying, what should I do with my insulin tonight? And I'm relieved to hear you say that there wasn't a whole lot of evidence you could come up with, because that was my experience as well. And I was kind of like, in the end, I just sort of gave up because, there didn't seem to be a whole lot of consensus. So
and as I say, it doesn't really matter. It doesn't matter, just so long as you have agreed on pathway that everybody's going to do. Yeah.
Yeah. Question in the Q&A says, during the COVID period, they had somebody whose HbA1c was 6.5, went up to 10 in 6 months, and they want to know how come. So I think that's probably something we've all seen, huh?
Yeah, we've all seen that. And then you explore individually with every patient what's going on, and all the stories differ. But I've heard some terrible stories about people, being severely depressed and stuff and letting everything go. And I think that's where all of us are trying to do all these virtual visits right now to keep everyone going and keeping them all feel supported and making sure they're on track and they're getting all their appropriate testing. So I think that's really common.
Yeah.
But on the other hand, we see the reverse. We see some patients that are actually using this as their window to get on top of things. So.
Absolutely.
And that's the guidelines. Dr. Alana Halprin, Janine Malcolm, myself, and one of my nurse practitioners were the ones that have submitted. Oh, sorry, read the question. They're saying they've submitted to the Canadian Journal of Diabetes. Yes, and we are waiting for that to be published, and it will have all of it in there.
Perfect. Yeah. I guess the only one that wasn't sort of maybe called out separately was some of the fixed ratio combination GLP-1 basal insulins.
Oh,
any comment?
True. We don't have a lot of use of them in our area. But it would be a challenge because you might need to separate the two out around the time of the procedure. Yeah. Do you have a lot of use of that in New Brunswick, or?
I think our uptake is probably similar to yours in that it's not, it's not huge, but it still does happen, right?
Yeah.
And to separate them out, there's often a significant cost, right? Because it's either going to be Lantus or Tresiba, which are neither one is cheap. So
yeah. No, that would be a challenge. You'd have to come up with an individualized plan, but you'd probably have to give them a separate drugs for a while.
There's another question.
almost came on this call at the wrong time. I did the math the wrong way. I just figured it out last night. There might have been dead air. Oh my God.
Oh gosh. So it said with GLP-1, would they take dose 1 week prior and not another until after the procedure? So I guess in your algorithm, that would depend on when their dose is scheduled. Is that?
But typically with the GLP-1s, it's not like super critical if you miss a dose. So I don't think your control would deteriorate that fast. Yeah.
And there was a comment about one of the initial slides indicating diabetes management and surgery. There was a website attached to it. Not sure if you're able to get back to that quickly or not, but do know that we will send out all the presentation slides and recordings as part of the post-conference emails. So there will be an opportunity to get that in the future. Yeah.
Yeah, and that was when I started working on this. That's where I started the National Health Service. They kind of beat the gun, and then we decided to make a Canadian version of it. So ours is probably even going to be a little bit more evolved than theirs. But that's the website there. NHS diabetes and surgery guidelines. You could just look for that. Yeah.
I'm not seeing anything else aside from
great. Well, let's have the big prize.
Yeah, absolutely.
I'll log off for that. Okay.
Thanks.
Fine. Thanks very much for inviting me. I did enjoy it. It's always exciting to use a new platform, and I was so happy with this choice of topic. Okay, thanks.
Thank you. Perfect. So we're nearing the end of the conference, and I'm now going to invite Nancy to help me. We're going to make the draw for the scavenger hunt prizes. There was 50 people that submitted their scavenger hunt checklist, so about 30% of attendees, so that's awesome. And in the interest of transparency, we'll make the draw here on the screen. We'll draw for 3 prizes total, which will be from NB Box, so all made in New Brunswick products. And I think that no matter who wins, you'll be very pleasantly surprised with the variety of products that are available to you. So draw number 1, our first winner is Annette Taylor. Congratulations, Annette. Perfect. We're going to move on to draw number 2. Our second lucky winner is Carinza Marsh. Congratulations. And last but not least, our third winner is Jose Duaron Tardif. So we will be in touch with all the winners within the next few days by email, and we'll let you know how you can claim your prize. So that's great. Before we go, I'll just do a few more thank yous and then a couple of reminders, and then we'll leave you to enjoy your weekend. Of course, first and foremost, thank you for attending and for your continued care of people living with diabetes in our community. Thank you to our sponsors. Without their generous support, of course, this conference wouldn't be possible. So be sure when they visit you that you thank them for continuing to sponsor our conference. Thank you as well to Kim and Christian and Nancy, the kind of behind the scenes people at the University of Health Network, for their guidance and support as we did our first virtual conference. So it was a whole lot of learning as we prepared to do this conference, and they were great to work with. So we do very much thank them. And also for the folks at the St. John Regional Hospital Foundation for their support with the registration platform. And last but not least, a big thank you as well to Michelle Corcoran, who's been a driving force in this conference for many, many years, and hopefully many years to come, Michelle, for all her leadership and creativity. So before we let you go, I really do hope that it was a valuable experience for you and that you've gained something useful for your practice. Recordings of conference sessions will be available for you for the next 3 months or so. A link will be emailed to you in about a week's time. Please complete the conference evaluation. You can find it as we switch out of broadcast mode and go back to the conference floor. You'll find it in one of the blue tabs at the bottom of the screen. If you're not able to complete it today, it will also be emailed to you. Now, the next question everybody always has is, how do I get my conference participation certificate? And of course, as soon as you complete that evaluation, it will be available to you. So please, please, please complete your conference evaluation, because we really do look at your evaluations for future topics, for formats. One of the big things this year will be, we had a larger than usual attendance this year. What do we want to do in the future when, hopefully COVID leaves us eventually? Do we stay virtual? Do we go back to in person? Is there a way to blend those? So we'll definitely be looking for your feedback on that. And I'm sure Michelle will want a closing word. So with that, I thank you again for your attendance. Take care.
Thank you, Erin. The only closing word I have is have a great weekend and a glass of wine on us. So hopefully you had a great day of learning, and we'll see you again when we see you.